Now, what is the pathogenesis of panic disorders? It can be genetic predisposition, so it can be running in the family. Number two, there can be some neurological issues, like issues with the GABA receptors in the brain. I don't want us to go into that because the QE1 does not focus on those things, right? It could also be childhood adversity. Maybe the patient had a traumatic childhood experience, right? It could be personality traits like patients who are naturally anxious. Okay, we have people like that, and I'm sure you've seen people like that in your consulting room, right? So patients who have anxiety sensitivity, these can all be issues. And what are psychosocial factors that influence panic disorders and panic attacks? They usually occur during periods of significant life stress. So, for example, if the patient loses a job, for example, if the patient loses a loved one, if the patient, is anticipating a stressful situation like going to court for a case, if the patient has a police case against him or her, these are all significant life stresses that can predispose the patient to panic disorder. Now, childhood adversity, such as physical or sexual abuse, can also do that. Childhood adversity, like physical or sexual abuse, increases the risk of developing panic disorder later in life. So maybe the patient gets into a situation which is very similar to, the situation they were in, which led to the abuse. That can cause a problem. And personality traits like high neuroticism and anxiety sensitivity are risk factors for panic disorder. So doctors, just pay attention to the top ones. Forget about the highfalutin stuff. Forget about those ones. Rather, focus on the things which we encounter in our regular clinical practice. So, according to the DSM-5 criteria, a panic attack is defined by an abrupt surge of intense fear or discomfort, and it reaches its peak in a few minutes. Now, what are the clinical manifestations of panic attacks? What are the clinical manifestations of panic attack? How do you pick that up? Because you should be able to see a patient who is presenting with symptoms of panic attack and say that this is a panic attack. This patient has a panic disorder. So usually they present with palpitations, which is similar to a lot of cardiovascular and metabolic conditions like hyperthyroidism, like arrhythmias. So that is one. And that is why cardiovascular conditions are a major differential of panic attacks and panic disorders. Number two, sweating, right? So if you remember, when we're reading the MCQ1 objective, they're talking about differentiating panic disorders from conditions like adrenal issues. So like pheochromocytoma can also present with excessive sweating. Trembling. Trembling can also occur in patients who even have hyperthyroidism, right? Shortness of breath. It can occur in patients with COPD. It can occur in patients with asthma. It can occur in patients with heart failure. That is why all those medical conditions are also differentials of panic attack. Choking sensation, chest pain. That's a serious, concern when you are dealing with cardiovascular issues. And that is why, cardiovascular concerns are a differential of panic attacks. And then nausea, dizziness. So you realize that vestibular issues, BPPV, all those things, Meniere's, all of them can be differentials of panic attacks and panic disorders. And then paresthesias. That is why we said diabetes, because you realize that diabetic neuropathy, they can have paresthesias in their hands and in their feet, glove and stocking distribution. That is it. Derealization, fear of losing control and fear of dying. Because the patient might have had, that near-death experience, that you realize that the patient might have had a near-death experience in the past. And so when they have that particular panic attack, then it's as if, death is coming, death is coming, death is coming. And that is how they usually will present it. What are some things which are associated with panic disorder? Number one, agoraphobia. And I will explain what agoraphobia is. Number two, substance use, and it can be, we in substance use disorders, we call something downers and uppers. So the uppers are the things which make the patient excited, like amphetamine, like cocaine. The downers are the things which, decrease the sensitivity of the patient, like opioids, right? So substance use disorder can be associated with panic attacks. And the patients at times may get hooked to these things to help them to overcome those, disorders and those sense of impending doom. And maybe a friend may pass a joint to them, or a friend may tell them that, hey, why don't you try this? And eventually they may get hooked to it. Okay. And they may have increased medical service utilization. So you realize that the least thing patients like that want to come to the ER, the least thing they want to be in the ER to be taken care of. Okay. And they may have reduced quality of life because, they are always working in fear. Reduced quality of life because they are always, always, always working in fear. And then they may self-medicate on alcohol or sedatives, and this can lead to substance use disorders and worsening of the symptoms. Okay. So these are the issues I really want us to pay attention to